Welcome to another episode of Stroke Rounds. I'm Dr. Gigi Kuritukulam, interventional neurologist, and today we are delving into a pivotal update which was presented in the World Stroke Congress in Abu Dhabi in stroke management. This is particularly concerning patients with atrial fibrillation. Our focus is on the optimal timing for initiating direct oral anticoagulations or anticoagulants or DOACs after an ischemic stroke, with a spotlight on the recent findings from the Optimas trial. This was presented in the World Stroke Congress recently held in Abu Dhabi. Understanding the clinical dilemma, atrial fibrillation is a significant risk factor for embolic strokes, which have a very high likelihood of recurrence. Anticoagulation therapy with DOACs is known to reduce this risk of developing a stroke. However, initiating anticoagulation too soon after a stroke may increase the risk of hemorrhagic transformation, while delaying treatment leaves the patients vulnerable to another ischemic episode or event. So this is the dilemma. The traditional guidelines which has been followed historically, neurologists and other clinicians looking after stroke have followed the so-called 1, 3, 6 and 12-day rule for restarting anticoagulation post an episode of stroke. 1 day after a transient ischemic episode, 3 days after a minor stroke, 6 days for moderate strokes, and we used to wait for 12 days following severe stroke. This approach of 1, 3, 6, 12 aims to balance the risk of bleeding against the benefits of preventing recurrent strokes. Introducing the Optimas trial, which stands for optimal timing of anticoagulation after an ischemic stroke with atrial fibrillation. This was designed to address this particular clinical question of when to restart or how early, or can we restart anticoagulation early in a patient who has had a stroke with atrial fibrillation. This was led by the chief investigator, Professor David Wirring at the University College London. The trial was a multi-center randomized controlled study funded by the British Heart Foundation. This study aimed to determine whether early initiation of DOAC therapy or direct oral anticoagulation therapy within 4 days of stroke onset is an effective and safe as a standard practice of starting treatment between 7 to 14 days post-stroke. The study design and methodology in this particular trial, 3,648 patients across 100 sites in United Kingdom were enrolled. The participants were diagnosed with acute ischemic stroke due to atrial fibrillation and who were eligible for DOAC treatment. These patients were randomized into two groups. One, the early initiation group. They received DOAC therapy within 4 days, that is 96 hours of stroke onset. That is almost immediate, within the first 4 days of stroke onset. And the second group was the standard initiation group. They received DOAC therapy between 7 and 14 days. The traditional, you wait for some time and then start after the 7th day or up to the 14 days after stroke onset, depending upon the severity of stroke. The primary outcome measured was a composite of recurrent ischemic stroke and second, intracranial hemorrhage or unclassified stroke or systemic embolism within the first 90 days after the index event. The key findings and the results which was presented at the World Stroke Congress 2024 revealed that, and published in Lancet also in October, revealed that early initiation of DOACs was non-inferior to delayed initiation concerning the composite outcome. Specifically, the primary outcome occurred in 3.3 participants in both the groups. That means a recurrent of an event. Importantly, there was no significant increase in the risk of intracranial hemorrhage in the early initiation group. That was the key finding. Now let us look at what are the implications of this particular study, the OPTIMIZE trial, for our clinical practice. These findings from the OPTIMIZE trial suggest that starting DOAC therapy earlier than traditionally recommended may be, one, safe, and second, effective for patients with atrial fibrillation following an ischemic stroke. However, the authors emphasize the importance of individualized treatment decisions, considering factors such as stroke severity, patients' other comorbid conditions, and also whether they are at a higher risk of bleeding due to other comorbid conditions. While the OPTIMIZE trial provides robust data, further research is encouraged to refine the guidelines and ensure optimal patient outcomes in those patients who are having an atrial fibrillation and recurrent episodes of ischemic stroke. In conclusion, the OPTIMIZE trial marks a significant advancement in our understanding of when to restart anticoagulation or the anticoagulation timing post-stroke in patients with atrial fibrillation. As we continue to integrate these findings into a clinical practice, the focus remains on a personalized care. Maybe in select situations, which is left to the treating clinician, one has to balance the benefits of stroke prevention with the risk of bleeding. Thank you for joining us in this episode of Stroke Rounds. Stay tuned for more episodes and updates on the latest developments as well as case reports in the field of stroke medicine. Thank you and see you next time with another episode.